Okay, so we are going live now, so give it about 10 seconds to start.
About 10.
Yeah.
Okay. Right. Good evening. My name is Reggie Blanding, and I'm a librarian at the James Brown African American Room of the Newark Public Library in Newark, New Jersey. On behalf of our director, Jocelyn Bolin-Dixon, and Board of Trustees President, Dr. Lauren Wells, we thank you all for joining us. I would like to acknowledge the traditional, ancestral, and unceded territory of the Lenni Lenape First Nations on which we are learning, laboring, and organizing today. We also recognize the devastation and the continued legacy of the transatlantic slave trade, which contributed to present-day systemic racism and oppression. A little about our space, my space here at the library. The James Brown African American Room was named in honor of the late James Library Brown. James Library Brown was a librarian, poet, and activist who was instrumental in making sure the library sought and maintained books and resources, as well as presented programs examining and celebrating the African American experience. Mr. Brown was especially committed to urging Newark youth to pursue education and to understand the importance of the library's role in their academic growth. So we just wanted to acknowledge Mr. Brown and his legacy, and hope we are carrying that forward. So thank you all again for joining us tonight. And I just want to thank our guests. So Susana Caparros and Dr. Amesika Nyaku. Dr. Nyaku is an assistant professor in the Division of Infectious Diseases at Rutgers, New Jersey Medical School, and a physician scientist. She is a graduate of Northwestern University Feinberg School of Medicine, where she completed medical school, internal medicine residency, and infectious diseases fellowship. She provides clinical care for people living with HIV and other infectious diseases. Her research interests are twofold. She's an investigator in the New Jersey Medical School clinical research, inclusion, and participation of racial and ethnic minorities in HIV-related novel therapeutics research. She is also interested in the implementation of treatment models that improve health outcomes for people with substance use disorders and HIV. She is co-director of the Northern New Jersey Medication-Assisted Treatment Center of Excellence that is tasked with assisting the state in expanding access to medication-assisted treatment for opioid use disorder. So I want to thank y'all both for joining us, as well as anyone who's tuning in. And before we just get into it, I do want to just acknowledge the lives lost, including a member of my own extended family over this past year, which has seen the world basically upended by the COVID-19 pandemic. At this point, thankfully, there's some light, much more light at the end of the tunnel than where we were a year ago, with the production of multiple vaccines. We'll hopefully get to a point where we continue to progress beyond where we are even now. And we've certainly progressed since March of last year. But even now, with the vaccine, there are still plenty of questions on the table. So, thankfully we have Dr. Nyaku to guide us, or explain everything that's going on, because it could be a lot to take on. For this, I reached out to several colleagues and friends online just to ask, and particularly those who are apprehensive about taking the vaccine, to ask them what their concerns and questions are. So we have Dr. Nyaku, who will break down and answer some of these questions, and Susana, who's gone through the trials already and can give us some insight onto everything she's experienced, maybe prior and since. So thank you again, Dr. Nyaku. I guess if we can get into it. I've got the first question ready.
All right, I'm ready.
Right. So the first questions. Is there truly enough research on the vaccine and its side effects to justify taking it?
So one of the, I'm going to take a step back so I can give a little bit more context about why I was invited to be able to speak on this matter. Because I know that in my bio, I talk a lot about my work around HIV and around providing better care for people with opioid use disorder and HIV. And really that kind of represents my pre-COVID life. So when COVID started, essentially, because a lot of the work that I do receives funding through the NIH, especially with clinical trials, part of the strategy, part of Operation Warp Speed, was for the government to use the existing research infrastructure that it has through the NIH, the National Institutes of Health, and have those groups that were already doing clinical trial research and knew how to do that, to have them stop what was their pre-COVID day job, and everybody focus on COVID. So, you had your infectious disease physicians and your immunologists and your virologists. We had folks from the National Heart and Lung and Blood Institute. So really, a lot of those resources that the government already has to do research, everybody turned their attention to focus on COVID. And that was in partnership with the pharmaceutical companies that, again, were funded or received part of their funding, many of them from the government, to focus not only on COVID vaccine research, but also treatments for people who were either hospitalized for COVID or maybe in the community and have COVID, so that we could develop treatments if somebody was infected. So for the last year, I've been spending the majority of my time focused on this COVID research, be it related to the vaccines or to different treatment strategies. And so hopefully this starts to lay a little bit of the foundation to talk about, how large this research enterprise has been. Frequently, people question whether or not we have enough information about the vaccines. And so what I like to break it down is for us to understand what we know and what we don't know. So vaccine research is something that has been going on for many, many years, and many vaccines use the same principles. So it might be a different target, a different focus of what we're trying to present, but it always has similar principles. So for instance, when we know that, how long does it take for us to know whether or not there's going to be side effects? For instance, we know that the side effects from vaccines usually show up in the first couple of months. So that's one of the principles that we have. Now, for us to get to the point where we were able to develop an effective COVID-19 vaccine is really actually building on years and years and years of research to understand this family of viruses. So SARS-CoV-2 is a coronavirus. Coronaviruses cause the common cold, but they have also caused other outbreaks in the past. So the first SARS outbreak, and when that happened, we thought this looks like this is something that could spread quite widely, like what we're currently experiencing. That was almost 10 years ago. And so they started, actually it was more than 10 years ago, they started to do research to develop a vaccine. However, that did not end up being widespread. So they kind of paused that work to develop a vaccine. Then we had the MERS outbreak, and MERS, again, being a cousin of SARS, that again reinvigorated that question of vaccine research. So then when we saw that COVID-19 was happening, which is caused by the SARS-CoV-2 virus, we were able to take all of that knowledge that had been built over the years and be able to rapidly use that to understand, how does this virus work? What is the best best way to target the vaccine to get our bodies to respond to develop protection. So this is actually work that's been going on for a long time, specifically around these coronaviruses. And then as a part of the larger knowledge we have around how vaccines work. And so I won't belabor this too much, but I do want to make sure to be clear that the current authorization, the current FDA approval, Federal Drug Administration approval, is an emergency use authorization, which is not our usual authorization. So normally we have, full authorization from the FDA when we have, either new devices or new treatments or new preventions come through, they get full authorization. So yes, this is a special authorization, and it is because of the toll that the COVID-19 pandemic has taken on all of us and globally, that they have used this emergency use authorization. This has been used before in terms of when we've had a flu outbreak and new flu treatments had come out, that then they had emergency use authorization for that. So it's in these times really of an extreme and unprecedented situation that you get the emergency use authorization. And what that means is that research is ongoing, and Susana can talk about that research that is ongoing, because we have very good safety information about the vaccines. And now the question is, how long does the protection last? And so that's the part of the research that is ongoing. And since the research is not completed, that is why the vaccines don't have the traditional FDA approval, but instead this emergency use authorization.
Great, and thank you for that. And I do want to, before we even proceed, also just acknowledge you as well as your colleagues that are putting in the work into, putting in work, just going through all this information and research and, to share with us. So let me acknowledge that as well. And just another part of this question, this is one of the first things that I got. And I think this is someone with a, somewhat holistic approach, but I don't know if there's any enough research at this point, but are there vitamins? I've heard this quite a few times, but are there vitamins, alternatives that, sort of maybe utilized potentially in fighting COVID-19 as opposed to vaccine?
So, right. So do I think that there is any enough data to say that there are other prevention strategies that are more effective than the vaccine? And so so the information that we have does not say that, for instance, vitamin D is more effective than getting one of these COVID-19 vaccines, or that using zinc is more effective. We don't have any research to show that. But what we do know is that when people are healthy, right, the healthier you are, the less likely you are to develop severe complications from COVID. So any of the things that one can do to maintain their health is definitely beneficial. And, and I think that health we should think about is both our physical health as well as our mental health, because the two are also connected, and so then this becomes an opportunity for us to think about what are the other strategies that become important. So social distancing, washing your hands, masking up if you're going to be in a crowded scenario. All of those things are going to be important complements to getting the vaccine. So, we can't say that, get the vaccine and otherwise, don't take care of your other medical conditions, because all of those the two end up being very important. And we should be thinking about this holistically.
That's great. Thank you. This is another part of that question, and I guess it has to do, more with trust. It was something initially out the gate that I did hear a lot and came up again when I asked questions, but someone did ask, why should we take this vaccine given the history of the CDC in the past with regards to things like the syphilis experiment? So I guess a comparison, a lot that has come up has been with the Tuskegee experiment. Is there a difference or something there that sort of separates that history that has made people apprehensive in some cases?
And we should clarify, and I can go back and double check on this, but the Tuskegee syphilis experiment did receive government funding, but it was not conducted through the CDC. And I can double check and verify that, but I do think it's important, right, for us to have that distinction so that because these institutions, right, can lose credibility. So yes, even though I said it's not the CDC that was responsible for doing this, but I did say that it did receive federal government funds, right? And so that's an important history that we need to acknowledge, right? But it's not only Tuskegee that we know that research has been used in ways that are human rights abuses, right? That have stripped people of their autonomy in the name of science. And so to deny that history, right? I'm not, my full disclosure, right, is that I receive funding from the NIH. I am a clinical trials researcher, right? I engage in research on human beings. And so I am very invested in this structure. And part of my investment and the others that I work with, not only as a part of the research team that I work with, so we research with the heart, we're at Rutgers, New Jersey Medical School, clinical research sites, as well as people that are a part of our larger NIH research network. We are very invested in righting those wrongs and changing and abiding by the protections that have been put in place because of these abuses that have happened in the past. So to kind of talk about the process. So if I have a research proposal and this research proposal can be specifically something that I'm going to test on an individual, is going to look at somebody's, I could just ask questionnaires. If I want to collect any blood, if I want to look at your medical records and look at it for research, anything that has anything to do with a human being, I have to write up the protocol and then I have to send it to what is called an institutional review board. So every university has this and many other organizations. If I'm going to do research that involves people, it needs to, my research, I have to explain what it is that I'm going to do. I have to detail the reason behind it, what I'm going to do specifically, which data I'm going to take, how I'm going to do it, how long, how often, how am I going to share this information, how am I going to obtain consent? So for the individuals who I'm asking to participate, how am I going to inform them about the research, let them know about the potential risks and the benefits, what I'm going to do with their data, what is going to get done if there's something that goes wrong. I have to detail all of those things, and it gets reviewed by somebody that is not a colleague, doesn't work with me, because they need to be unbiased. The purpose of that activity is to say, is this science good science? Is it worth it? And could it potentially harm somebody unnecessarily? Once I get that approval, then I'm able to start in the research process. And so all studies, big or small, now are required to go through that, because it is for the protection of the participants and the protection of their data. So all of these studies for COVID have gone through that institutional review board process. Additionally, there is a safety monitoring group. So all the information in terms of, for the blood work, people's symptoms, anything that happens, all that information gets collected, and then we send it to the study teams, and then the study teams have to report that to this independent data safety and monitoring committee. And so that committee meets at intervals, and it depends on the type of study, how frequently or infrequently they meet. And as a part of meeting, is that they review and they look and they say, this group had, 5 events, this group had 3 events. Do we think it's okay to continue the study or not? What about the study procedures? Are they doing what they said that they were going to do when they did their initial application? And again, it's an independent group, because we don't want people to be swayed by, connections that they may have, so that if there's a problem, they will stop the research. So like, for instance, when we've had to have these pauses for different concerning events that may have happened while participants were on study, it's under the Safety Monitoring Review Board that is waiting to make a determination about whether or not the study can go forward. So these things that we've been hearing in the news are an example of the protections that have been put in place to prevent those abuses from happening. And I'll stop here because I can go, in much more detail, and we can do some more questions around that.
Okay, thank you. Yes, and I had a couple things going through my head, words I was thinking of as you were breaking that down, but it sounds like a more transparent process than maybe what other people may have been thinking compared to sort of like the event that we spoke of earlier. So that's, good to hear, or comforting to hear. So another one of the early questions that I had gotten is in regards to the recent cases with Johnson & Johnson and AstraZeneca. And someone asked, why should I feel safe following the recent incidents with these 2 items, which are currently back on the market?
So for the Johnson & Johnson, that is something that is available here in the United States, right? AstraZeneca is not currently have the FDA emergency use authorization for distribution, but it is being administered in other countries around the world. So the question, I think it's an important question, right? Because any of our decision making has risk. If we decide to do something, there's a potential risk, right? And if we decide not to do something, there can be a risk associated with that. And so for each individual, we have to figure out what we find to be acceptable risks. So for instance, you may say for the issue around the Johnson & Johnson and the severe blood clots that have been rare, but it has happened, you may say, I think that that's an unacceptable risk, even though it may be very small. So instead, you will prefer to get one of the Moderna or Pfizer vaccines. I think that when people are weighing the risks of in their choice, I do think that I think that we have enough options, enough vaccine options, that it shouldn't be no vaccine versus a particular vaccine, because there are several options that are available. But even with these rare blood clotting events that have happened, there are still millions and millions of people that have received the Johnson & Johnson vaccine without any significant adverse event that have happened. So yes, it's good that we have an awareness and that we highlight this potential risk so that everybody's informed around the decision making, but we do have to really kind of weigh what is the probability of something like that happening when we're making our decision. And like I said, if you feel that even that very small chance of it happening is unacceptable, there are still 2 other vaccines here in the United States that are available to you.
Thank you. I have 2 more questions, and I'll have a few for Susana after that, and then jump back into it. But just 2 more, just in the first section of questions I have for you, Dr. Nyaku. And I think this is a pretty important, a good question that they're all good questions. There's no bad ones. And also, before I proceed, I do want to acknowledge, I see there's a few questions in the Q&A, so I will do my best to get to those as well, throughout the course of the program. But one of the questions that someone has asked was, if I have to continue to wear a mask, why should I take the vaccine, especially if masking and social distancing have been effective so far?
So there are several different, so first we can talk about how well does, masking and social distancing work, and how well does the vaccine work. So none of them are 100%, right? So we know it's the masking, there's still kind of a question. We don't have it very well pinpointed because there are all sorts of different types of masks and what's the situation and those things. But why don't we just say roughly that, wearing a mask and social distancing, or specifically wearing a mask, reduces your chances of getting COVID by 50%. We'll just be rough. That can be a lower end of 30%, maybe it can be as high as a 70% reduction, but it cuts your chances in half. Getting one of the COVID vaccines, it can reduce your chances, we'll say by 75% or even as high as 95%. But there's always still a chance in any of those situations. So now if you put the two of them together, right, and you're in a crowded environment, now you've gotten additional protection for each of those, for that to be put together, because remember, none of them have 100% chance of reducing 100% effective in reducing your chances of getting COVID. So that is the main reason, because nothing is effective, and we know that the variants are going around, and as we continue to have variants that develop, the effectiveness of the vaccines in reducing your chance of getting COVID may go down. Though we still have more research that needs to be done in that area. But we do know that the vaccines are quite effective, that we're saying, well, if people are vaccinated and they're mixing with households where everybody else is vaccinated, you don't have to wear your mask, right? We're saying that you can go outside, and as long as it's not crowded, you don't need to wear your mask. And that really has a lot to do both with kind of being outside and it not being crowded, but also the benefit of so many people already being vaccinated.
That's great, thank you. And one more question, I'm just gonna break it up and then I'll ask, have a few for Susana, but someone who's maybe kind of leaning towards taking the vaccine, they asked, is there a vaccine that has, proven more effective, particularly kind of a two-parter question too. Johnson & Johnson requires one shot, whereas Pfizer and Moderna require two. Does this speak to the effectiveness of one over the other or potency?
So the Moderna and Pfizer vaccines are based on mRNA. So basically, the mRNA being the message, or I like to think about it as the recipe that your body needs to be able to start to produce the antibodies. So that recipe makes your body create a piece of the outside of the virus, one of the spikes. Your body makes the spike, and then it says, wait a minute, this isn't something that's supposed to be in our body. So then your immune system turns on and gets rid of it. And that process is the process that's needed to get your body to be able to create antibodies in the future when exposed. Now you've got the Johnson & Johnson, and since we mentioned AstraZeneca, I'll put that in there, that's a DNA based virus. And this DNA based virus, vaccine rather, this DNA based vaccine comes in and stimulates your body to, again, create these antibodies. So it's a different mechanism, and because it's a different mechanism, you need different numbers of doses. So to get the Pfizer and Moderna to achieve such high levels of protection, you need that first dose, and then you need to go through it again. So we can think about that as a boosting. So that's the situation for those mRNA, whereas for the DNA based vaccines, you only need the single shot. And that single shot actually technically only applies to the Johnson & Johnson.
Okay, so yeah, definitely thank you for clearing that up. I know a lot of people, actually, several people have questions about sort of the differences, like why, there's one and then why should I get two? So I thank you for that that answer there. And so we have Susana with us as well, who is actually taking the vaccine, trial participant. So a few questions for you just regarding any leading up to it and effects following. So the first question we have is, how did you learn about the opportunity to volunteer in the vaccine trials?
Hi, first of all, I just want to thank you for having me here today. It's a great service to be able to do. And I didn't know that this was going to be happening, but I knew that I would be sort of an example for others. And that's why I did research on the trial. The first time that I heard about I was always interested in how they were going to come up with a vaccine. So I followed the news, and whenever I heard anything about the vaccine, my ears would perk up. And I learned that there was, and Dr. Nyaku maybe can speak to this, that one of the reasons why Moderna was able to develop the vaccine so quickly, because there was a Chinese scientist who actually posted the genetic code of the virus online. He probably risked a lot to do that, but that was one of the reasons why I think also it just sped up the process of being able to come up with a vaccine. We can maybe get some confirmation on that in a little bit. But so I followed the vaccine progress. I saw the first person getting injected on television, and I really thought, wow, I was very impressed. I was so relieved that they had developed something, and that it was coming, and it gave me hope. And I thought the person was very brave. So it was a month later, not even a month later, a few weeks later, I saw that they were calling for volunteers. UMDNJ, they were requesting for volunteers for the phase 3 trial. And remembering that man on television getting the first shot, I immediately called up. And I said that I was a minority. I knew that they were short on volunteers. I'm Spanish. I'm Latina. So, I thought, I know they needed, minority testing in minority populations. They were very gracious. They answered all my questions. I made an appointment. I went in, I showered them with questions. I made them dizzy with questions. I know just enough about science to make, a nuisance of myself. But, they answered all my questions. I met the team. I was very confident about the team at UMDNJ. It's called the COVE study, the study that they were doing. And then I contacted my experts. I had someone that had worked with HIV years ago in New York, who was a doctor. She gave me the thumbs up. I contacted my primary care. He gave me the thumbs up. I told my family I wanted to do it. They were okay with it. And that's how I became, sort of a trial volunteer. On September 14th, I had my first shot.
Thank you. And you alluded to it. This is actually one of the questions that I did have for you. I heard you mention phase 3. And someone was wondering what is phase 3 of the Moderna trials, if you could speak to that.
Yeah, I mean, phase 3 is they recruited 30,000 or 33,000. And maybe Dr. Nyaku again can talk about phase 1 and 2, but that's when they get it to, I think that's the last phase that they go through where they put it out to the largest amount of public. I just want to state that I am not getting paid for being here today. I am not getting, I was paid a stipend, a small stipend by Moderna, I think just to cover my expenses for getting there. Like the first one was $150 to join the study, $150. And then I think they put $50 in my account every visit I get. You know, I go in, now I think I'm going in every 6 months and they take vials of my blood and they're testing to see how effective or, you know, what's going on with the vaccine in my body and my blood. And I fill out an app every 2 weeks, no, every week rather, about have I come in contact with anyone with HIV and do I have any health changes? So whenever I want, there's a whole team of doctors there for me. And yeah, I feel very secure. So I'm going to be in the study for another 1.5 years.
And that's good. So it's been an ongoing, just sort of follow up and fairly consistent as far as that is going. So
Yeah. In the beginning, it was closer together and now it's further apart, but they still take 8 vials of my blood and they test it and they keep in touch with me to make sure that everything is going well. And if it wasn't going well, I'd be in touch with them in no time, but I've been really healthy.
That's great. And Dr. Nyaku, did you have any comments on, we just mentioned phase 3 or any of what Susan has talked about so far as the trials?
Yeah, so for the, so the process by which we want to develop some sort of therapeutic, intervention, prevention, first we will do it we'll talk about like in the Petri dish. So we'll do it, in the Petri dish under the microscope. And then from under the Petri dish and under the microscope, then we do it in animals. And then after testing in animals, that's when we're able to move into humans. And in the first phase 1, it's only a few people. We want people that don't have whatever, if there's a disease that you're either trying to treat or trying to prevent, we don't want them actually to come in contact with that because we don't know whether or not this is going to even work at all. And we're trying to figure out if there's any sort of side effects. So again, you've had some very careful studies that were done in what we call preclinical trials. That give you a reasonable sense that this is safe, but now you're going into in a very small number of people, so maybe 20 people or less, you're going to test it and make sure that you see that it is safe. That's phase 1. And then in phase 2 ends up being a larger number of individuals. So maybe you'll end up with, let's say, for instance, 100 individuals. And they may have the condition that you're interested in treating, or maybe potentially at risk for the condition that you're trying to prevent. Again, this will be generally a fairly healthy group of individuals. And again, you're testing to see, well, what is the right dose? What's the right dose that will get whatever either treatment we're looking for or get the level of prevention that we're looking for, and also limits the number of side effects, be it, that the individual experiences or or based on their blood work. So that's a phase 2 study. Now a phase 3 study takes that information. So we've found the right dose where it appears to work and it appears very safe. And now we really need to test it. We really need to see what happens. We get more and more people enrolled. And so for these vaccine studies, this has been in many ways, we've made history with how many people we've enrolled in these vaccine studies, because even these are incredibly large phase 3 studies. For each of them to have, approximately 30,000 people enrolled, those are actually very large, and it's very rare to have a study of this nature be so large. But when we think about, we're trying to give this to, our global population, we say, well, we really need to know about the safety and about whether or not this is going to work. And and to clarify, the vaccine studies, these phase 3 vaccine studies are what we call randomized placebo-controlled. And so in these studies, roughly half the group gets the active and half the group gets what we call the placebo. So that can be the sugar pill, or, in this case, it's the saline water injection. I don't know who gets what. The participant doesn't know who gets what. It's only a very small number of people. So like the pharmacist or research pharmacist that makes up the either the active injection versus the placebo injection, that person knows, but you're actually not supposed to talk to them, so that there's no way to then I get the information, or the other researchers get their information. Susana can talk about the fact that we had, 2 sets of, study team that would interact with her, so that because we aren't supposed to, because you really are supposed to be maintaining the fact that you're blinded to which group, whether it's the active group or the placebo group, because we don't want anybody to influence, either the way that Susana is reporting her symptoms or the way that we are interpreting her symptoms. So we really kept everything separate.
That's great. Thank you, Dr. Nyaku, for the further clarification on the various phases. Susana, and so I was going to ask before, prior to your, participating in the trials, were you diagnosed? Was there any COVID-19 diagnosis before? Prior to that?
No, absolutely not. I'm fairly healthy, but, and I don't know what they tested. They tested my blood, they took my history, but, I had no symptoms of COVID before the study. And as Dr. Nyaku mentioned, it was a randomized control trial. And the only person that knew if I was getting the vaccine or the saline, shot was the nurse that was giving it to me. No one in the study knew. And I was asked to be willing to go through 25 months once I had the first shot to not know. However, the reason why I do know now is because of the emergency use that they approved in December. And it was no surprise to me that I was the vaccine recipient, because my first vaccine that I had, my first shot, I was really disappointed because I had no symptoms whatsoever. And I thought, oh, I got the saline, darn. The second one, I had some reactions. I had really strong reactions, and I was scared, you can imagine, but I reminded myself, you have a whole team with you. This is what you're doing. You're doing it for this reason. And I too had a close relative that died in April 14th of a year ago. And that was one of the reasons why I did it. But no, I had no COVID before, and I actually went back to school, a second career, right at this stage in my life, and I was working in a mental health clinic as an internship this year. Yes, at my age, I did it. And I worked there all year long, and there were COVID cases that the staff came down. I wore my mask, I kept my social distance, I did what I was told. But I must tell you, when I got once I got that shot and I knew that I had it, I felt that I was free. The level of anxiety went like this. I no longer felt that if I pressed the elevator button that I, myself or somebody in my family could die. It was really a freedom. So anyway, thank you.
Thank you. And you actually answered one of my next questions, which I had, which was, did you experience side effects from the vaccine from the first or second? You did mention
I did,
that there were.
but I'm still here.
You're here to tell us about it.
I'm
So
happy. Yeah.
indeed, thank you. There's a few questions here for you. I don't, due to time constraints, unfortunately won't be able to get to them all, but one that I did want to ask you, so, as we're still learning, if there is a follow-up required, annually, 6 months, et cetera, would you, I guess, repeat the process or, continue to vaccinate?
Myself, would I take another booster or vaccine? Absolutely.
Yes.
Absolutely. I'm fine. As I said, I'm healthy. I don't have any side effects, whatsoever. Nothing strange is happening. I have to document that. I did want to, so the answer to that question is absolutely. Once they find out that if we need a booster or another kind of vaccine, I will do that. I'll do my research on it, research the research. And I also want to say that, and I think Dr. Nyaku mentioned this, that one of the things, if you're hesitant about the vaccine, if you have some sort of condition, there were people in that phase 3 trial that had, that had physical conditions. I was surprised. I wouldn't quote the percentage, but I thought, my goodness, they were brave. They had, I don't know if they call them concurrent or comorbid conditions, but they also volunteered for the trial. So there might be some information about that as well to talk to your doctor or to ask Dr. Nyaku about right now, or how to get that. So it's a long yes.
That's correct. That's a big question that comes up about who participated in the studies. And roughly about a third of the individuals who were in the studies were either had some other medical condition, be it, high blood pressure, heart disease, lung disease, diabetes. We know that, our weight is associated with increased risk. And so had people that were overweight or obese also that participated in the study or had kidney disease, liver disease, or were over the age of 65. So there was a sizable portion for not only the Moderna study, but for the Pfizer and for the Johnson & Johnson. So in that phase 3, it was no longer that restriction to, only healthy people can participate. It really was trying to make it be more similar to, the real world, what the United States looks like, what the world looks like in the participants.
That's great. Thank you. Thank you both. So I have a sheet of paper here with questions, but I'm also looking at the Q&A. And I think so. There's one question about breakthrough cases, so I do want to jump into that a little bit. So just they're asking, would you please talk about breakthrough cases we've been seeing in people who've been fully vaccinated, maybe the number of cases so far, severity of breakthrough cases, and how many, also how many patients, maybe it's been the opposite for, and do we have data, basically, do we have data on how many cases have been progressive or shown progress?
So I don't have the most up-to-date numbers because when I was looking at the release of information about breakthrough cases at that time, and that might have been maybe we'll say 2 weeks ago, it looked like something on along the lines of 0.00005% of people who were vaccinated ended up contracting COVID. And we should remember that if you get COVID right after you get your first shot, right, there's a large possibility that you already had COVID, right? So you wouldn't count in that group. And then we say maybe it takes about 2 weeks from your first shot for you to really start to get the benefits of being protected. So even if it's in that first 2 weeks, that ends up being a gray area, right, about whether or not you have that protection. And then we know if you're getting either, the Pfizer or the Moderna, you need that second shot. So there's a potential, we'll say roughly 5 to 6 week period after getting your first shot that you can be vulnerable still to COVID. But again, what we see is that, these number of infections have been very, very, very rare. And the vast majority, and again, not having full, information of the most up to date, but the vast majority end up being quite mild cases. And so having hospitalizations and then, having hospitalizations that are so severe that the person ends up in the ICU is incredibly, incredibly rare.
Great, thank you. And maybe, I think there's one or two more. I don't think I'll be able to get to them all, but I do want to ask this one. And there's another question in there about the Moderna vaccine. And I'm not sure if we may have spoke to this some, but someone asked, there are rumors that I will need to get a booster shot. How true is that? And how soon will I need to take it? So that's, if we, about that.
So that's definitely one of the questions that is on everybody's mind. The researchers are very much included. We want to know, how long does this protection last? Some of the most recent information that has come up, is that we see that you are at 6 months, you continue to have 90% protection. Again, so a 90% reduction in the risk of getting COVID. So the question is a twofold question. One is, what's the level of protection that is okay, that we say, okay, this is pretty good. And when it falls below that level, then you need the booster to bring you back up over that level. Because when we originally were thinking about how well do we need the COVID vaccines to work for us to be able to go forward with the emergency use authorization, we said if it works like 50% of the time, we were going to be happy. Because for instance, the flu shot works, is 50%, efficacy. And so we said, okay, that's good. So when it came out that we had over 90%, with the Moderna and Pfizer for all cases, and in the 70s for the Johnson & Johnson, but 100% reduction in severe infections and hospitalization, that kind of changed our perspective. So we haven't come to a decision yet about what is that level of protection that we want to keep a vaccinated person at. And so we don't yet know when people will need to get boosters. Our suspicion is that we probably will need to get a booster, but we haven't flushed that out yet.
Great, thank you. And maybe there's a couple from one person in the Q&A. I am kind of curious because I think at the root, I don't think I got any questions about this, and I know it comes up a lot, and it is, I know it's a much broader term, but maybe in this context here of medical racism occurred and still occurring, and I think maybe that has to do with some apprehension. So I don't know if you have any thoughts on that question in the Q&A.
Yeah, I have lots of thoughts, and I don't know that we have enough time to really delve into it. I mean, it's for that reason that it motivates me to do the work that I do, because we have, for others, to kind of the perspective that I'm coming at this is this question of why is it that certain groups of people get a certain standard of care or have a certain level of health, and why is it that other groups do not, right? And so we can see that, and so what is this difference that happens? And so often this difference that we see in levels of health and healthcare are poorer when you're a Black or brown person, right? But it also happens if you don't speak English, right, in the United States. We can see differences in health outcomes between men and women, right? So, and what are the reasons why this occurs, right? So we can talk about our society and the racism that exists in our society, and that in the structural racism that occurs, and how that then permeates into medicine, right? And so like we were talking about for Tuskegee, that the medicine can and definitely has perpetuated racism, right? And so the work that I do and the folks that I work with, and our desire to actually engage the community, is to undo and halt that continued racism in being continued, not only both in terms of the way that research is being done and who's able to participate and have the opportunity to, so that, when we have certain groups that are excluded and not represented, right, that is a continued perpetuation of that racism, right? When now we have these new therapies that come out and certain groups of people are unable to access those therapies, right, that's a continuation of that racism. So I definitely believe it. And we see it in the fact that COVID, who has been most severely impacted by COVID, right? And we see that it has been our Black and brown communities that have been severely impacted, right? So in terms of the health, and poor outcomes, we've seen that occur. But then also we see the racism that occurs as well, that when we see the anti-Asian sentiments that continue to be perpetuated, and this idea that somehow now people are being targeted because of the perception that they're Asian or Asian American, right? That's another form of that racism that then kind of overlies in all of this. So I 100%, agree, acknowledge, and am trying to work against the racism that exists in our society and permeates at all of these different levels.
Thank you. Yes, thank you for that answer. And as you stated, we could have a whole program, more than an hour, to even get into the full history and scope of that. But the great answer, and I appreciate that. We are at 7. These things always go quicker than I expect. And if you both have the time to remain beyond that, we can just kind of take it over for a few minutes. So I do think there are still a couple really significant questions. I may not be able to get to them all, but I'll try to pull the best of the bunch here. One, I think, also still on people's mind, or the current status of, we have widening access to vaccinations, but it also at least appears that COVID cases are still rising despite this. So I don't know if you have if you're able to speak to that, or basically why are cases still on the rise at this moment, despite the broadening access to vaccinations?
Yeah, I mean, this is the thing that we talk about for herd immunity, that in order for us to reach the point where we have, for those that we talk about this term herd immunity, and just to kind of quickly bring everybody on the same page. It's this idea, so let's say you have 10 people and nobody is vaccinated. So that means all 10 people. So if one person, gets infected, then the other 9 people are able to get infected. Whereas if you have those same 10 people and 8 of them are vaccinated, and one person becomes infected, so one of the 2 people who is not vaccinated, what is the chances of that other person getting infected? Well, if we know that it spreads person to person, and one person who's infected comes in contact mainly only with people who are vaccinated, then the chances of that infection spreading to that other person who's not infected becomes very unlikely. So we have not yet reached the point where so many people are vaccinated that then the few people who are unvaccinated and the few people who are unvaccinated and get sick are therefore not coming in contact with each other. And so that's we're kind of in the middle right now of where we need to be. And in terms of us being able to get that herd immunity that protects the people who are unvaccinated, we need, 85, 90% of people to get vaccinated. And we're not there yet.
Okay, thank you. Thank you for that answer. A couple of these I know we touched on already, and actually this is a good time for anybody who is watching and who may have missed part of the program or who may want to revisit, that we will have this posted up on YouTube, on the Newark Public Library YouTube. So anyone who may want to revisit or share, please within the next few days, absolutely do so. Tell a friend to tell a friend, and so forth. So maybe not as many questions as I thought. I know we already touched on how likely it is people who are already vaccinated will have to get vaccines again. That's still I think we said a TBD, to be determined at this point. We're still learning about this. This was one that came up several times. Will there be a vaccination passport? Are there legal, moral, or ethical problems associated with identifying those who refuse? So I don't know if you have any thoughts on that.
I mean, that is something that is complicated, without a doubt. I think that we can talk about, what are the scientists saying, right? So what are the scientists saying? Right now, the scientists are not saying that, this, immunization passport is what needs to happen. And we know that at this juncture, the people who have not been vaccinated, right? There's still people who are still trying to access, very much wanted and still trying to access, but there's also a lot of people who have questions, right? So many of the folks that are watching right now, as well as people who said, no, I don't want to get vaccinated. And for us to, for the science to kind of now say you have to do this and you're restricted, and say that that is, good scientific practice, that's not coming out from us, because we know that there can be reasons why people don't get vaccinated, because choice is important when people are making an autonomy, when they're making their medical decisions, and because we know that there are other things that people can do to reduce their chances of getting COVID. So to now say that, the only thing that is effective is to get vaccinated, especially when this vaccine is not 100%, right, is going to hurt the cause rather than help it in many cases. Now, what private businesses do, right? What communities decide to do. Now that ends up being, potentially based on consensus, or, if you're, a business owner and you decide that this is what you want to have or not have, what you may want for your workers so that you can protect other workers and all of those different things, that may be where we see that. I know that, there are countries that are saying if you've been vaccinated, then we'll let you, come and see us. And that at the same time, those countries aren't necessarily mandating that their own citizens be vaccinated, right? So it's an interesting, if you really kind of start to think about that, right? So, and you can say maybe from a country standpoint that might make sense. You don't want to have variants introduced and stuff. So it's like, if you're vaccinated, then you can come in, and then because they're, trying to think about it from this standpoint. I mean, vaccination definitely literally opens up a lot of doors. for people to start to go about more closely to regular life than before. But yeah, this is a lot of very complicated. And Susana, I don't know if you want to share on some of your thoughts about this, because I know it's a lively debate for all.
Yeah, I agree with you. I've thought about some of the things you just talked about. You know, I think it's going to be a discussion that we all have to have. I don't think you could regulate private industry. But it's going to be interesting to see what our government does for its citizens. And will we remain free to choose? And I've been in this country about 50 years, a little bit over 50 years. I've never, ever experienced any mandate on health. However, we do understand that there are some issues with vaccines with kids going to school, right? So more shall be revealed. I don't think we know enough yet to, know what's going to happen in the future. I think at the end of maybe the study that Moderna is doing, I expect some of this information to be available to us. But it will be interesting to see what happens, in the near future. In the meantime, I hope, that all of you remain safe, and all your relatives and all your loved ones, because there are still people that are dying out there, nearby. I just had somebody, at my internship, one of my coworkers, her mother, who did have comorbid, the caretaker that came in to her home brought in a cough. The mother died, and the father, who was perfectly healthy, died a month after the mother. So it's still happening out there. Yeah. So, thank you.
Thank you both. And yeah, that's a good reminder there, is that yes, it's still, even with everything going, vaccinations, everything still going on. So I think this is kind of maybe what I would have asked earlier, but it's here now. So, is it okay to visit my unvaccinated grandchildren? Yeah, I guess, yeah, if someone, yeah, so if I guess, is it better to visit family that's already vaccinated? That seems like an obvious answer to me, but I will definitely let you take that one.
Right. So the question is, right. So we've been in lockdown, right? We've been social distancing, and human nature is that we want to be around other people, and especially around, our family. And so this time of separation has just been, it has been, a tremendous hardship for all of us. And so now you're vaccinated, and so you're like, okay, what can I do? But right now we are, the vaccination of children, especially small children, is not something that is available. So how do we proceed? So one of the things that I encourage you to do is to go onto the CDC COVID site, so that you can stay up to date as the CDC issues more guidance on what people are able to do. But so the CDC does say that mixing, so limited, right? So it's not going to end up being, unfortunately, we can't have yet, full family reunions, right? But limited mixing of, folks that are completely vaccinated with those that are not, is something that can be done. And again, we always say that instead of it being in kind of like indoor setting, it's much better outdoor. So thank goodness that we are now moving into spring. minus the rain, so that we can be able to have now, those backyard cookouts and picnics and, and get together and be able to give those hugs and things like that. And so I think this goes back to what I had talked about earlier about making a decision, right? That if we decide, not to see the grandkids, right? But you miss them so terribly, right? That's a risk, right? Whereas if you go and see the grandkids, but you've been vaccinated, what is your likelihood that you're going to get COVID from them, right? So that goes into that decision making that we're doing all the time. We're doing all the time.
Great, thank you. Thank you so much. I have one more question I want to ask. Before I do that, I do just want to acknowledge just a couple comments. Anasa Mat says, thank you for this very useful information, which also I mirror that comment as well. Both of you have been great. And another comment, yes, from Ingrid, great conversation. Thank you to both the speakers and the facilitator, but my hat's off to both of y'all. Appreciate y'all so much for this. Hopefully ending on a message of hope. The final question that I have is there light at or near the end of the tunnel for 2022, or maybe even sooner? And both of you could speak to this. But start with Dr. Nyaku.
I mean, I remain very hopeful. I mean, this has been challenging. Challenging doesn't even describe it. This was not my, if I knew that I would see so much sadness and loss as a part of my work as a physician, it would have really made me think twice about going into this role. Because I really, as physicians, we love to be able to help, and restore health and keep people healthy. And, a year ago was, the exact opposite of that. And, even 6 months ago, I would say was the exact opposite of that. So just reflecting on how things have changed, even in the last 6 months, it feels different, and so I am and continue to be very hopeful that things will continue to get better. We are still going to have some bumps in the road, because things are changing, with this virus, as well as, trying to get, folks that continue to still be, just not so certain that they want to do this, to continue to get them to think about it a little bit differently. I'm also very optimistic because we have better and better medications that we're finding to treat someone if they are exposed, or if they get COVID. And now we're to the extent that we have some very promising, medications if you're exposed, but you do not yet have COVID, to keep you from getting COVID. So if you live in the household with somebody. So, I mean, there are all of these advances that are happening that definitely make me feel very, very optimistic. When exactly will, this will be all in our rear view mirror, I can't say if, it'll be by 2022, but I'm hopeful.
That's great. Thank you. Thank you for that. And as I said earlier, actually, thank you both, because, we move forward with, what y'all have done, but we learn, when Susana does the trials, the work that you put in, you and your colleagues. So, I definitely want to thank y'all both. Susana, if you have any thoughts either on that question or just any closing thoughts, comments.
I do. I think it's a great question, because it's looking forward. What do we expect, or, what do I see? I mean, I'm not a scientist, I'm not a doctor, but, I have enough life experience. And I know that after every tragedy, even looking back at World War I, the advances in plastic surgery, were born out of, the disfigurement, since it was trench warfare, right? There were a lot of horrible injuries, and the whole, I think, practice of, plastic surgery came as a result of it, from the physicians working on the front. I think that there's a lot of questions that remain to be answered. But for instance, the origins of the virus, everybody, there's no certainty about that. I think in order to avoid future incidents, I think that we need some closure on that. But in spite of that, I think a lot of good will become of it. I'm so happy that Dr. Nyaku and the likes of that, a doctor of that, stature and dedication is with us. So I'm glad she didn't know it was coming. But, I think we will be forever changed. But, let's look at the glass half full rather than half empty. We might never really stop wearing masks in the subway of New York City. I don't see myself taking that mask off in New York, no matter what, right? I will wash my hands probably 5 to 10 times a day for the rest of my life. But that's a small price to pay. I think that we have to take a look at some of the positive things that are coming our way that we don't yet know as a result of this experience, but we will be forever changed. Anyway, thank you so much for having me here.
I just want I thank you both for joining us, and also just my colleague Diego for IT in the background for making sure everything's running smoothly, as well as Yesenia Lopez, my James Brown Room colleague, Dale Colston. And yes, just for the umpteenth time, on behalf of Newark Public Library and absolutely myself, I thank y'all both for joining us tonight, and for anyone who tuned in. Thanks again. Please, everyone, be safe. And any closing thoughts, or we can just all just close out from there. So
Thank you so much. I really appreciate this opportunity.
thank you. All right. Good night.
Thank you so much. Have a good night.
Good night. Take care.